In this lesson, we will finish our general discussion of pulmonary diagnostic tests. Included in this discussion are PFTs, ABGs, and oximetry, and lastly, cytologic and hematologic tests. We start our lesson by looking at the most common pulmonary function test. They include spirometry to measure FVC, FEV1, FEV1 to FVC, and vital capacity, diffusing capacity to look at the integrity of the alveolar capillary membrane, and indirect measuring of residual volume, often by helium dilution tests. Other ways to measure residual volume, expiratory reserve volume and functional residual capacity, are body plethysmography, or body box, which employs Boyle's law, and nitrogen washout tests that also gives us these measurements. As we know, the main tests to differentiate obstructive versus restrictive lung diseases are the measurements of FEV1, FVC, and the ratio of FEV1 to FVC. In normal lungs, this ratio is generally above 75 to 80% of predicted. In restricted diseases, it may be normal or increased due to both FEV1 and FEVC being reduced. And in obstructive diseases, this ratio will be very decreased due to the reduction in FEV1, which represents the volume of air a patient can exhale in 1 second. Other tests of interest are FEF 2575, which gives us an idea of the integrity of the medium to small airways, and FEF 200 to 1200, which looks at large airways. MVV, or maximal voluntary ventilation, which tells us about the respiratory muscle strength, and PEF, or peak expiratory flow, which we often use to evaluate treatment response in asthmatics. Tests for diffusion capacity, or DLCO, is generally affected by 3 key factors. 1. Decreased hemoglobin or anemia, as carbon monoxide used in this test must have hemoglobin to bind to. 2. Increased thickness of the AC membrane, often seen in restrictive lung diseases such as asbestosis. And 3. Decreased functional surface area for diffusion to occur as seen in COPD patients. As a quick summary, in obstructive lung diseases, we will see volumes and capacities either normal or decreased on the inspiratory side, and increased volumes and capacities on the expiratory side due to air trapping. For restrictive diseases, all volumes and capacities on both the inspiratory and expiratory side will be reduced due to a decreased compliance or opening of the lung. In obstructive lung diseases, all flow rates will be decreased as patients have difficulty getting volumes of air out and require more time to remove this volume. In restrictive patients, flows may be normal or reduced, but again, the definitive test to differentiate the two groups is the FEV1 to FVC, also known as the Tifano-Pinelli index. Our next topic we'll very briefly review is blood gas analysis. As we know, it is used to determine acid-base balance, ventilation, and oxygenation. Typical ABG results reflect pH, PaCO2, PaO2, SaO2, bicarbonate, and base excess. When assessing the adequacy of alveolar ventilation, we determine a patient is hyperventilating when PaCO2 is less than 40 millimeters of mercury, hypoventilating when PaCO2 is greater than 40 millimeters of mercury, and ventilatory failure when PaCO2 is above 50 millimeters of mercury. When assessing oxygenation status, we identify a patient as mildly hypoxemic when PaO2 is in the range of 60 to 80 millimeters of mercury, moderately hypoxemic when PaO2 is between 40 to 60 millimeters of mercury, and severely hypoxemic when PaO2 is less than 40 millimeters of mercury. We also use oximetry to measure the affinity of oxygen for hemoglobin. It can also be used to measure dyshemoglobins, such as carboxyhemoglobin, which is increased in smokers, and methemoglobin, which may be increased with inhaled nitric oxide, a potent vasodilator used in pulmonary hypertension, and with certain medications such as nitroprusside, dapsone, benzocaine, and lidocaine. Other tests respiratory therapists may find helpful in assessing their patients are electrolytes, complete blood counts or CBCs, and coagulation studies. Sputum collection analysis often leads to a definitive diagnosis depending on the bacteria, fungi, protozoa, or virus, and can lead to a more targeted treatment plan. CBCs include red blood cells, white blood cells, hemoglobin, and platelets and white blood cells are further broken down into neutrophils, eosinophils, which are elevated in allergic reactions and allergic asthma, basophils, lymphocytes, and monocytes. Lastly, of interest are evaluations of blood clotting tendencies and can be evaluated by obtaining platelet counts, partial thromboplastin time, PTT, prothrombin time, PT, and bleeding time. Normal results for PTT are 32 to 70 seconds. Normal PT is 12 to 15 seconds. To standardize bleeding times across various laboratories across the world, clinicians use INR, which is the International Normalized Ratio that adjusts these differences. Anticoagulation levels are achieved with INR of 2 to 3.